just get set up here. All right, just checking online that my slides look good. Great. Okay, so thank you all for coming either in person or joining online through the Zoom. Today I'll be going over my research entitled Using Time-Lapse HRPQCT for Bone Turnover Classification in CKD-MBD Patients. To give a quick outline of what I'll be talking about today, I'm going to start with the background, going into really what this disease is and where in the course of treatment we're coming in, and then the imaging modality that we're using to kind of optimize this process. I'll then get into the study design, really what that question that our team is ultimately trying to answer and how we went about doing that. And then preliminary results. I'll note here this is an ongoing study, so as we speak, we're still getting data, so this is just a snippet of what we expect to see. And then lastly, some concluding remarks. So starting with the background, what is CKD-MBD? That acronym stands for chronic kidney disease, mineral and bone disorder, and it's defined as a systemic disorder of mineral and bone metabolism due to chronic kidney disease, and it's manifested in either one or a combination of the following, so abnormalities in blood-bone biomarkers, bone turnover, or calcification in the vasculature or other soft tissue. So there's a lot to unpack with that definition, but the key takeaway is that with CKD and that abnormal bone metabolism, that leads to low bone mineral density and a high risk for fractures in these patients, and that's ultimately what we're trying to address here. How do we classify these patients for treatment? The most common way is to determine their bone turnover, and this is done by doing iliac crest bone biopsy. So right at the top of the hip bone, we'll take a sample of that bone, and they're doing this with tetracycline double labeling and quantitative histomorphometry. All of that to say is we're administering a fluorescent compound that gets integrated into the bone at 2 different time points. And you can kind of see here on the image how it's integrated into the bone. And we're measuring that distance between those 2 lines, and that will help us determine a rate of turnover. And this is a very important step because the way in which we treat this abnormal turnover is quite opposite depending on the type of turnover they have. So for a high bone turnover patient, we're really trying to slow that down. And for a low bone turnover patient, we're trying to speed it up. And for example, if you were to give a medication that will speed up that process in a patient that has high bone turnover, you're really going to exacerbate a lot of the issues that they're already having. So we want to make sure at this step we're getting it right. So with the gold standard of the bone biopsy, there are some shortcomings. It is an invasive process. It's pretty limited in its availability in that not every hospital can perform it. It's typically performed only once because of the invasive nature of the procedure in that one location. In terms of time, it could take up to 3 months to get the results from histomorphometry. So if we were trying to do rapid decision making for patients, probably not the best choice to go with. And then lastly, the identification of some of those histological features is still pretty subjective. So this is kind of where our imaging comes in. We're using high-res peripheral quantitative CT. And this is a research imaging modality that can measure volumetric bone mineral density, bone geometry, and bone microarchitecture. And it's really nice because it's in vivo. We don't have to make any incisions on the patient. We can acquire images at a low radiation dose and a high spatial resolution. So we're getting all the way down to about 60 micron. And at this level, we're able to really differentiate between the cortical and trabecular bone. So you can just see an example of what an image from the scanner looks like on the slide. It's very detailed. You can see all of the fine structure within the bone and even in the outer boundary. And there's been some recent developments using this imaging technique in a time-lapse fashion. So taking sequential scans at the same anatomical site, and because we're able to image at such fine detail, we can not only observe, but we can also measure the changes over time. And the thought here is maybe we can utilize this technique to perform a virtual biopsy. And so just a quick comparison between the gold standard and the potential of this imaging technique. With imaging, it's non-invasive, can be performed multiple times at various peripheral locations, and it is more objective. To date, however, this has not been applied to CKD-MBD patients, and that's where this study comes into play, is we're really asking the question of whether or not we can utilize HRPQ-CT for bone turnover classification. We're specifically trying to address these three aims. So the first one is determining the least detectable in vivo bone turnover that we can measure. The second is determining the shortest period of time with bone turnover greater than that least detectable value. And then lastly, doing a comparison between the gold standard of bone biopsies and time-lapse analysis. For our study design, starting with our participants and the timeline for them in the study, we're recruiting 15 individuals that have chronic kidney disease and are undergoing dialysis. We are excluding those that are already getting treatment for their abnormal bone turnover, so those that have anti-resorptive treatment, anabolic treatment, or have had a kidney transplant. And then looking at the figure for the timeline, all volunteers will undergo a baseline visit, and at that visit they're going to have 3 repeat scans, and then all of the follow-up scans will be done at a 2-month interval after that. For image acquisition, we scanned at the distal radius and tibia. All of those images then went through a semi-automatic segmentation using 2 different analysis protocols. So one is the standard analysis and the other one is a Laplace-Hamming analysis. And as we were going through the segmentation, we were performing manual edits as needed to the, if you can kind of see it in the images, those green lines, those green outlines. And then all of that funneled into our time-lapse analysis. And so the steps to actually perform that are as follows. We're registering all those scans to the baseline image. We're then doing a voxel by voxel subtraction to find the differences. We filter the image to get rid of any noise. And then lastly, we're calculating some time-lapse parameters. And so I kind of list them here, but it's a little easier to see on this slide. We're looking at the bone formation fraction, which is all the voxels that are denoted as bone formation divided by the baseline total bone voxels. We're doing a similar thing for the resorption, and then total bone turnover is just a summation of those 2 fractions. Lastly, there's some just statistical analysis once we get the results for all of the 3 aims. So for aim 1, as I mentioned, we're trying to calculate that least significant detectable change. Aim 2, we're comparing the turnover at a follow-up visit to the least significant change. And then lastly, we'll do a linear regression to determine the association between biopsies and time-lapse. So all of that to get into our results. So as I mentioned before, this is an ongoing study, so this is, again, just a snippet of the results that we hope to have in the near future. Starting with our image processing, we see just a result of our segmentation using the two different processing methods. So on the left is the standard analysis, and then on the right is the Laplace-Hamming analysis. And it's pretty clear, but I also denoted it with some red arrows, that using the standard analysis, there's area in the trabecular bone where bone isn't identified. And then similarly, looking at the cortex, or that bright outer edge of bone, there's a lot larger cortical pores. And in some cases, specifically with image C, there's even some breaks in the cortex. All of that seems to be addressed when running the images through the Laplace-Hamming technique. Additionally, with image processing, we did a parameter study to try to determine the best time-lapse global threshold, and so we can see the results of that here. On the x-axis, you can see all the different thresholds that we tried. And for the yellow line, from previous studies, I believe this is the value with which other studies is able to measure total bone turnover in vivo. So matching that and then looking down at what threshold that takes us to, that's around 450. And so looking at some of the results from comparing our results from a baseline scan to a follow-up of our CKD, we see that percent change for the radius, we've increased almost 300%. So we're seeing an increase in bone turnover from after a 2-month visit by like quite a large number. And then for the tibia, we're seeing an increase of 57%. So still a good amount of, a good percent increase with the tibia as well. And then just as we continue to go through the study and refine our image processing pipeline, we hope to calculate the LSC values for our cohort of CKD patients to really see what our bone turnover percent changes really mean in terms of the least significant change. And then also we hope to continue to see an increase in total bone turnover measurements at subsequent 2-month follow-up visits. So to just kind of discuss some of those results, starting again with image processing, it was pretty clear that the Laplace-Hamming technique was a much better workflow for this study's needs. We were better at identifying the detail in the trabecular region, the pores and edges in the cortical region. And then for the parameter study, this really helped us with optimizing and determining the global threshold for time lapse. And then for the for the results on the follow-up, it showed very promising results for both the radius and the tibia. Because those numbers, especially for the radius, were so high, maybe that could garner a conversation of making that follow-up scan visit shorter, but obviously that will take getting the results from the AIM-1, which is our least significant change value, first before making that decision. And I believe I forgot to mention this when going through the results, but a thing to note on that result was that we weren't actually comparing the results from the same patient over time, so it would be good to see what the baseline visit for that patient compared to the follow-up really looks like once we get that data. And then lastly, just some other challenges that we had in the beginning of this study was recruitment. So CKD patients go into the clinic 3 days a week for dialysis, and so sometimes trying to convince them to come in for a 4th visit on the same week could be a little bit of a challenge. So that's something that we face, but we are definitely in the midst of getting through that, and we hope to finish recruitment soon. And so lastly, just to kind of wrap everything up, we found that Laplace-Hamming was the optimal processing technique for this study. We were able to narrow the time-lapse parameters to kind of continue moving forward with processing. And then we had some pretty promising preliminary results with respect to the measuring the total bone turnover for the radius and the tibia. This is still ongoing work, so we're continuing to analyze images as we speak and finalize recruitment for this study. And with that, I just wanted to acknowledge all the people that have been in my corner helping me through this process. So my PI, Dr. Gladia Kazakia, who unfortunately couldn't be here today, my committee for their added mentorship in their areas of expertise, and then Sagi for working with me week to week, sometimes day to day, to make sure that my research is going in the right direction. And with that,